Good afternoon. Our lecture for this afternoon would be community diagnosis and problem prioritization. Who could really say that I am a community organizer? We've had our community organizing lecture previously, and we know that community organizing gives us the power to solve problems for our own and make decisions for ourselves. So again, is the process of building power through involving a constituency in identifying problems they share and the solutions to those problems that they desire. Identifying the people and structures that can make those solutions possible, and listing those targets in the effort through negotiation and using confrontation and pressure when needed. Building an institution that is democratically controlled by that constituency that can develop the capacity to take on further problems and that embodies the will and the power of that constituency. So we have three O's in organizing. So we have the organizer, the action of organize, and to make an organization. We build things from the people for the people. In Filipino, that is mula sa tao para sa tao. And this is the definition of empowerment in organizing. It's a multi-dimensional social process that helps people gain control over their own lives and fosters power in people for use in their own lives, communities, and society by acting on issues they define as important. We start with social investigation. It's a method of investigation that consists of the preliminary gathering of data and information prior to launching an organizing effort in a community. And this is my favorite example to show the beauty of organizing. If we are organized, small fish taken as one could beat an even bigger fish if we just work together. Hence, our lecture for this morning, community diagnosis and problem prioritization. So what is a community? It's a cluster of people with at least one common characteristic, so either geographic location, occupation, ethnicity, housing condition, or a group of people with a common characteristic or interest living together within a larger society. You, as medical students, Indian medical community could be considered as a community. It's a whole entity that functions because of the interdependence of its parts or subsystems. 8 subsystems plus the community core are identified. The community core is basically the demographics of a community, its history, socio-demographic characteristics, vital statistics, values, beliefs, and religion. And to diagnose a community, it refers to the identification and quantification of health problems in a community as a whole in terms of mortality and morbidity rates and ratios, and identification of their correlates for the purpose of defining those at risk or those in need of health care. This process is a means of examining aggregate and social statistics in addition to the knowledge of the local situation in order to determine the health needs of the community. The goals of community diagnosis is to analyze the health status of the community, evaluate the health resources, services, and systems of care within the community, assess attitudes toward community health services and issues, identify priorities, establish goals, and determine courses of action to improve the health status of the community, establish an epidemiologic baseline for measuring improvement over time. So how then is the community diagnosed? So we have community analysis, and this is the process of examining data to define needs, strengths, barriers, opportunities, readiness, and resources. The product of analysis is the community profile. To analyze assessment data, it is helpful to categorize the data, and this may be done as the following: demographic, environmental, socio-economic, health resources and services, health policies, study of target groups. And of course, we use different health indicators. So indicators of health are variables used for the assessment of community health. And the characteristics of these indicators should be valid, so they should actually measure what they are supposed to be measured. Should be reliable and objective, so the answer should be the same if measured by different people in similar circumstances. They should be sensitive. They should be sensitive to changes in the situation concerned. It should be specific. They should reflect changes only in the situation concerned. Should be feasible. They should have the ability to obtain data needed, and should be relevant. They should contribute to the understanding of the phenomenon of interest. There are different classifications of health indicators. There are indicators of mortality, of morbidity, disability rates, nutritional status indicators, healthcare delivery indicators, utilization rates, indicators of social and mental health, environmental indicators, socio-economic indicators, health policy indicators, quality of life, etc. So mortality indicators would include the following. So mortality rates is the traditional measures of health status, and this is widely used because of their ready availability. So death certificate is a legal requirement in many countries. True death rates, its specific death range according to age or disease, expectation of life, infant mortality rate, maternal mortality rate, proportional mortality ratio, and case fatality rate. Morbidity indicators are data on morbidity are preferable, although often difficult to obtain. So incidence and prevalence, notification rates, attendance rates, so outpatient clinics or health centers, admission and discharge rates, hospital stay duration rate. There are disability indicators as well. So number of days of restricted activity, bed disability days, work school loss days within a specified period, expectation of life that's free of disability. There are nutritional indicators that we could use, such as anthropometrics for pedia, height of children at school entry, prevalence of low birth weight for maternal outcomes, clinical surveys that would show anemia, hypothyroidism, and night blindness. So healthcare delivery indicators. So this is very prominent nowadays. So reflect the equity and provision of healthcare for disease. So doctor to population ratio. So it's been said in a statistic that there are just 28,000 people who are doctors in the Philippines. And divided into a population, it just goes to show the doctor population ratio is very bad. More so the doctor-nurse ratio. population to bed ratio, population per health center, and this becomes more emphasized in a pandemic such as the coronavirus, which shows overcapacity of beds, especially in Metro Manila. Utilization indicators. So healthcare utilization rates. So extent of use of health services. Proportion of people in need of service who actually receive it in a given period of time. So the number of infants who are fully immunized in the first year of life. So this is immunization coverage. Proportion of pregnant women who receive antenatal care. Hospital to beds occupancy rate. And this is becoming a problem with the pandemic, with most ICU beds and ventilators being utilized with no more room for additional patients. And the hospital beds turnover ratio. And this is what happens when you have a prolonged quarantine, meaning admission is quite longer, hence the decreased availability of beds. We have our social and mental health indicators. So this will be valid positive indicators that does not often exist. Indirect measures are commonly used. So we have heard people committing suicide due to the pandemic. It's an increase. Road traffic accidents, alcohol and drug abuse. So we have environmental health indicators as well. So it reflects the quality of environment, measures of pollution, the proportion of people having access to safe water and sanitation facilities, vectors density, and socio-economic indicators. It's not a direct measure of health status, but for interpretation of healthcare indicators. So population increase rate, per capita GNP, level of unemployment, literacy rates for the females, family size, housing conditions, etc. And of course, health policy that is made for health. So proportion of GNP spent on health services, spent on health-related activities, how PhilHealth spends its budget, total health resources devoted to primary health care. And other indicators, such as indicators for quality of life and basic needs indicators, and health for all indicators. So, seeing all these things, we see a lot of problems that we could intervene. Why is there a need to prioritize? We need to prioritize because resources are limited. Problems have different magnitudes, and problems have different sizes. So prior to prioritization, we have to have a proper community assessment, the agency to self-assessment, clarify the objectives and processes, and establish criteria. Commonly used prioritization criteria would be to identify the problem. Cost, return of investment, are the solutions available, the impact or magnitude of the problem, are resources available, solving the problem urgency, and size of the problem. Identify interventions. So do you have the expertise to implement solution? You look at the return on investment, effectiveness of solution, ease of implementation. There are potential negative consequences, legal considerations, impact on systems or health, and feasibility of intervention. So we have 5 prioritization methods that we could use. Multivoting Technique, Strategy Guide, Nominal Group Technique, the Hanlon Method, and the Prioritization Matrix. The multi-voting technique is used when there is a long list of problems which is needed to be narrowed down to a few. So, step 1, there's a round 1 vote, then you narrow down choices, and then vote again until the desired number of priorities is reached. So, this is like nominating a past president. You list down names of the nominees, then you vote one by one, and then you narrow down the choices. Strategy grids facilitate agencies in refocusing efforts by shifting efforts toward addressing problems that will yield the greatest results. So you select a criteria, and we create a grid and we label the quadrants. And then we categorize and prioritize like the following. So we categorize it into 4 quadrants, showing interventions that would show low need and high feasibility, meaning the community does not need it but it could easily be done. An example would be parenting classes in a primarily aging community with a low teen pregnancy rate. So there is a low need and low feasibility, meaning there's no need for the intervention in the community and it is not easily done. An example of which would be investing in health education materials in Spanish in a community with a less than 1% non-English speaking population. There is also a high need but low feasibility, meaning there is a need for this intervention, but it is not easily done. An example would be access to dental care in a community with a largely uninsured population. And the most ideal would be a high need and high feasibility, meaning there is a need for the community and there is a high probability that it could be executed. So high blood pressure screening program in a community with a rapidly increasing rate of stroke. Another example would be the nominal group technique. This is useful in early phases of prioritization when there exists a need to generate a lot of ideas in a short amount of time and when input from a lot of individuals are needed to be considered. The steps are the following: establish a group structure, silent brainstorming, generate lists in round-robin fashion, simplify and clarify, group discussion, anonymous ranking, and repeat if needed. Another method is the Hanlon method. So, a complex method, the Hanlon method is advantageous when the desired outcome is an objective list of priorities based on data and numerical values. So, step 1 is rate against a specific criteria. So, this is the Hanlon method sample criteria rating. So, you rate it from 0 to 10, then size of health problem, then the seriousness of health problem, and the effectiveness of intervention. And then you rank it like so. So the Hanlon method depends on the Pearl test, which is propriety, economics, acceptability, resources, and legality. So to calculate priority scores, D is your priority score, and A represents the size of the health problem ranking, B is the seriousness of the health problem ranking, and C is the effectiveness of intervention ranking. So, rank the health problem. So, the next one would be Prioritization Matrix, and this is the most commonly used tool for prioritization. And this is ideal when health problems are considered against a large number of criteria or when an agency is focusing on only one priority health issue. So you create a matrix and rate against a specific criteria. 3 is met well, 2 is criteria met, and 1 is not met. So like the Hanlon, So you list the problems and then you list the criteria and you assign specific weight and you compute like so. So our activity would be to apply this health prioritization problem prioritization matrix into Cuento ni Rosario in the background of COVID. So your assignment is to make a strategic grid of the interventions that could help us solve the problem of coronavirus in our country or in an Indian setting. Thank you for listening to the lecture. Please subscribe to my channel for more lectures on preventive medicine and community health. Thank you.